session. I think it's time to start. So, good afternoon, dear colleagues and dear friends. It's really a great pleasure to welcome you all to this AFRAN ISN joint webinar entitled "The Kidney Transplantation in Africa: From Challenges to Actionable Initiatives." Today's webinar is a valuable opportunity to take stock of the current situation of kidney transplantation in Africa, and above all, to present for the first time a major initiative of the AFRAN Transplantation Committee, the development of comprehensive guidelines for the first time on how to create and maintain kidney transplant programs in Africa and in low and middle income countries in general. As chair of the AFRAN Transplantation Committee, I am very delighted to see such a strong and diverse audience joining us today for this important session. This webinar reflects the spirit of collaboration that is essential for advancing kidney transplantation across Africa. I would like to express my sincere appreciation to the International Society of Nephrology Transplantation Working Group and the ISN Africa Regional Board for co-organizing this event with us. We have an excellent program today, and I warmly thank our speakers, Professor Mohammed Saleh Eddin Zaki, Professor Intisar Hadia, and Professor Wesley Tulkan, Professor Mohammed Saleh Zaki from Egypt, Professor Hadia from Morocco, and Professor Wesley from South Africa, for their contributions, as well as my co-moderator, Professor Augusto Cesar Soares dos Santos Jr. from Brazil. Before we begin the scientific program, it's my honor to introduce my dear friend, Professor Mohammed Saleh Eddin Zaki, who will share his opening remarks, of course. Professor Mohammed Saleh Eddin Zaki is a professor of internal medicine and nephrology and Dean of the National Institute of Urology and Nephrology in Cairo, Egypt. He serves as a General Secretary of the Egyptian Society of Nephrology and Transplantation and the Arab Society of Nephrology and Renal Transplantation. Within the International Society of Nephrology, he is a member of the ISN Council and Deputy Chair and Chair of the Africa on the ISN board. And since the beginning of this month, he has been serving as President-elect of the Middle East Society for Organ Transplantation, the MISOT. Nationally, he plays several leading roles, including moderator of the Nephrology Division of the National Committee for Egyptian Guidelines at the Ministry of Health. He is head of the Supreme Committee of Nephrology at the General Organization of Teaching Hospitals and Institutes, and a nephrology representative in the National Committee of Non-Communicable Diseases. So, dear friend, Professor Zaki, it's a great pleasure to have you with us today.
Thank you, dear Professor Mongi, for this kind introduction, and thank you for organizing such an important event together with the International Society of Nephrology, represented by the Transplantation Working Group, of course, in collaboration with AFRAN, the Transplantation Committee of AFRAN, which you are the chair of this committee. We can see how much it developed under your leadership, with the crown jewel of the transplantation guidelines that you developed with your colleagues in the committee, and I had the honor to be one of the revision board for such a very important edition of the guidelines, which really take into consideration the current situation in most of the African countries, being of low and middle income countries, with some challenges that we'll go through in this presentation. Before I start, I would like to welcome my dear friend Augusto from the Transplantation Working Group, the ISN Transplantation Working Group, Professor Intisar Hadia from Morocco, and Professor Weasley Tulkan from South Africa. Also, I would, if you give me the honor to introduce you, you introduced me, I would like to introduce you. To those who are not familiar, who is Professor Mongi, it's my pleasure to introduce him. Professor Mongi is Professor of Nephrology at the Faculty of Medicine, Tunisia, and he's Transplantation Unit, Department of Nephrology at Charles Nicolle Hospital in Tunisia. And he is the Vice President of the Tunisian Society of Nephrology, Dialysis and Kidney Transplantation, member of the Scientific Council of the National Center for the Promotion of Organ Transplantation, and chair of the African Association of Nephrology Transplant Committee, among many other local and regional and international participations in the National Kidney Days, in the donation awareness in Tunisia, etc. So Professor Mongi, and I think now Professor Mongi also is the president-elect of the ASOT, the African Society of Organ Transplantation. He was elected, I think, 2 or 3 months ago at the ASOT conference in Egypt, in Cairo. And we are looking forward for his contribution with the ASOT in this field. So I'll transfer the phone, let's say, to Professor Augusto, if he would like.
I would like to present
Yes, please.
Professor Augusto. It's really a great pleasure to have Professor Augusto with us today to co-moderate this webinar. Professor Augusto is adjunct professor at Faculdade de Ciências Médicas, Minas Gerais, Brazil. Is nephrologist at Hospital das Clínicas Universidade Federal de Minas Gerais, Brazil, and a pillar of the ISN Transplantation Working Group. So really, it's a great pleasure for us, Dr. Augusto, to have you with us for this webinar, joint webinar, AFRAN ISN.
Thank you so much for the kind introduction. It's, of course, my pleasure to be here today and learn from our key speakers on transplantation and its challenges in the African context. It's also my great honor to introduce our first speaker of the day. So Professor Mohammed Salah El-King Zaki from Egypt. Professor Zaki is the chair of the ISN Transplantation Working Group and also the ISN African Regional Board. He has been a leader in advancing kidney transplantation and kidney care across the African continent. He will speak on kidney transplantation in Africa, current situation, and barriers. Professor Zaki, thank you so much for being with us today. The floor is yours.
Thank you, dear Professor, for this kind introduction. Is the slides are clear now?
Yes.
So we will start talking about kidney transplantation Africa, the challenges and the opportunities. Of course, as I said, this is part of the ISN Transplantation Working Group, collaboration with AFRAN Transplantation Committee. Sorry. No, is this bar obstructing anything? Try to take it off. No, I will take this off. Okay. So as you all know, that the mission of the International Society of Nephrology is to work on advancing kidney health worldwide and to guarantee an equal access to care regardless of geography. And of course, one of the major things in ISN, especially the Transplantation Working Group, my dear colleague Augusto shared with me two previous sessions for the group, and the main concern was supporting developed, underdeveloped or low-income countries or developing countries or countries which have not yet established a good dialysis transplantation program, especially in Africa, to increase the capacity of these countries to how they can get better transplantation program. As you can see in this global transplantation activities of solid organs 2020, you can see that most of the African continent comes with the color with no data or very sluggish data. Unfortunately, this is the situation. Well, kidney transplantation in Africa is expanding, but still reaches only a tiny fraction of patients who need it. The burden of kidney failure in Africa is significant and growing, driven by high prevalence rates of CKD, around almost 18% in sub-Saharan Africa, and a severe lack of access to treatment like dialysis and transplantation. Even dialysis has many challenges in Africa, unfortunately. Common causes of CKD in Africa, including hypertension, diabetes, and infectious like HIV, unlike in developed countries where non-infectious causes are dominant, which add to the challenges. The financial burden is immense, as most patients must self-fund their care due to low health insurance coverage, leading to catastrophic health expenditure and high mortality from preventable causes. Again, this is the kidney transplantation activities in 2017. And again, you can see that Africa has no color. I call it this way. We don't have much countries, less than a handful of countries that have data to share, or some of them have activities, but they don't have registries, so they don't show on the international registry. Africa kidney health landscape, it's the fastest growing, as I mentioned, still limited access. And on the left-hand side, this map, you can see that African countries where transplantation is currently available, they are less than half of the countries of Africa. And most of the African countries on the right side, the light blue color is where countries data, they don't have data, or they don't have transplantation program from the beginning. Disease burden, impact on organ transplantation Africa, as I mentioned, infectious diseases, especially tuberculosis, hepatitis, and HIV, and non-communicable diseases like any other part of the world, mainly diabetes and hypertension. The question is why we do this effort, why we want to transplant, to promote for transplantation, why it matters. Well, because it's the most cost-effective therapy. It's better for survival versus dialysis. It's essential part of ISN global mission. We are ISN promoting for this. Part of our mission is to to introduce better quality of life to our patients. In terms of survival, you can see the huge difference between those on transplantation versus those on dialysis. You can see how much the life expenditure and the lifespan is affected being on dialysis versus having kidney transplant. And here is some of the cost of the transplants in some of the African countries. You can see there is big disparities between from country to country in terms of the cost. Transplant activities in Africa, only 20 to 25 countries perform transplants, majority less than 5 transplants per million population. The major inequities across regions, we have overall burden versus transplant activity. Africa has a rapidly rising CKD and kidney failure burden driven by hypertension, diabetes, infections, and genetic diseases. Yet only a minority of African countries have any kidney transplant program at all. And in many of those activities, very small number of patients, or it is intermittent. That means that sometimes they have some transplants and then they have a long period of pause, they don't transplant, and then they go back again for transplant, few cases, and etc. In African countries that report data to the ISN Global Kidney Health Atlas, the reported transplant incidence is typically, as I mentioned, below 5 per million population, compared with up to 30 to 60 per million population in high-income regions. The key message here is that the need is huge, activity is modest, and extremely uneven across the continent. This is a publication in 2023 by the ISN, the knowledge about renal transplantation among African, Caribbean, and Black Canadian patients with advanced kidney failure. And again, you can see the huge differences between those, and the participants with kidney failure in this transplant show that there is this big gap between the demands versus the actual or the real transplants has been done. I can go through some of the regions of Africa, because even within the same continent, we have some differences. In North Africa, the countries like Egypt, Tunisia, Algeria, Morocco, and other have long-standing kidney transplant programs with both living donors, and in some countries, deceased donor activity, but still not that much. Despite weak registries, published series show that 1 year patient survival is more than 90, and graft survival more than 85, comparable to many middle income settings and even some high income settings. In sub-Saharan Africa, the condition is a bit not that flourished. Only in a handful of sub-Saharan African countries like South Africa, Nigeria, Ghana, Kenya, Tanzania, Sudan, and few others have regular transplant services. Many other countries have either no program or very small sporadic activities. South Africa is the main deceased donor hub in sub-Saharan Africa, but even there, the overall kidney transplant rate is about 6.4 per million population, with stark public-private disparities, 4.8 versus 15.2 per million population. Newer programs like in Tanzania and Kenya are largely living related and have shown encouraging short-term outcomes, but remain very small, often less than 50 to 100 transplants over several years. And mainly these countries, like what happened in Kenya, depends on surgeons and transplant teams coming abroad with some difficulties, as we all heard in the last few months. So in sub-Saharan Africa, the kidney transplant recipients' characteristics, they are younger than seen in Europe and US, male preponderance, nephropathies like chronic glomerulonephritis, hypertensive nephrosclerosis are major, poor compliance with medications and appropriate follow-up. And even if this compliance is not because of the patient's lack of compliance, sometimes because of the resources, the patient had transplant and then he cannot find proper laboratory to do the investigations, the follow-up investigations, or sometimes there is lack of some medications. Actually, I found this myself, because in Egypt, I had many patients from our African countries, our brothers from Africa who came to do transplants in Cairo. And when they go back, some of them contact us and tell us that they are not able to do the proper follow-up post-transplant, or sometimes they don't have access to medications. Of course, there are many barriers. We'll go through it so as not to waste our time. And this, I have to refer that this slide is an infographic by our dear host, Professor Muhammad Mongi Pasha, with the AFRAN Transplant Committee. Well, the donor type and registries across the continent, transplantation is dominant by living-related donors. Deceased donation is established in very few countries, and unfortunately, some other countries have living unrelated donors. According to the latest ISN Atlas, mandatory national transplant registries exist in only 40% of African countries where transplantation is available, so true activity is probably underreported. And key message here is few countries and centers carry most of the activities. Living-related transplantation is the backbone, and registries and data are weak. Outcomes overview. Despite all the constraints where transplantation is done, outcomes are generally good, as I mentioned, comparable to other parts of the world with higher income countries. And the main, of course, adverse events is infection, acute rejection, CNI and tacrolimus, especially toxicity, and post-transplant diabetes, and often reflecting both resource limitation and infection burden. So quality is not the main limitation. Access is one of the limitations. So let's go through the major barriers quickly. Service delivery and infrastructure. Only a limited number of transplant centers, mostly in large cities and tertiary hospitals. Vast geographic areas have no local access. Insufficient ICU beds, laboratory capacity, HLA typing, cross-matching, DSA monitoring, etc. Interventional radiology, renal pathology, all are very seldom found in most of the African countries. Organ procurement organizations and structured deceased donor pathway is not also largely available and only in few countries. Health workforce, market shortage of nephrologists, transplant surgeons, coordinator, transplant nurses, pathologists, etc. Brain drain, brain drain. Many trained specialists leave to work in high-income countries, and this is an important cause of lack of expertise in our continent. There is limited formal training programs and fellowship in transplant nephrology and surgery within the continent, dependence on short external fellowship and visiting teams. Financing in many countries, dialysis and transplantation are largely funded out of the pocket, which is a big catastrophe, and only a minority of patients have insurance schemes that cover a full transplant pathway. Even where the operation is subsidized, immunosuppressive drugs and post-transplant follow-ups are not reliably funded, leading to non-adherence and late graft loss. Of course, some of the countries, including Egypt, we finance the patients, whether for the operation or post-operative, but this is not in most of the other countries in Africa. Donor evaluation, travel, and lost wages are often not reimbursed. If the donor was traveling to donate to his brother, let's say, and he will stay at home after the operation for convalescence period, so his work will not cover this gap, and this also discourages the living donors to go for donation. Governance, laws, and ethics. Several countries lack clear organ transplantation legislation, brain death laws, or enforceable frameworks for ethical organ donation. Where laws exist, implementation can be weak, no centralized allocation, limited oversight of living unrelated donations, and fears of organ trafficking or transplant tourism. This is a diagram that shows the ethical dilemma, where if you have legal and ethical challenges in organ transplantation, Africa will lead to also a lack of informed consent issues, equitable allocation, lack of regulatory framework, and of course, the ethical concerns. Patients level social and cultural barriers. Patients often present late with advanced comorbidities, uncontrolled hypertension, diabetes, infection, malnutrition, making them poor transplant candidates. Limited awareness of transplantation among patients and primary care providers, and many believe that dialysis is the only option or that transplant is only for the rich. And cultural and religious concerns about organ removal, especially from the deceased, myths about body integrity after death, and mistrust of the healthcare system. Actually, this is a major barrier for deceased donor programs in most of the African countries. Gender and the socioeconomic inequities. Women and the poor are less likely to receive a transplant, but may be more likely to donate. Unfortunately, this is also the case in some countries. Information systems few robust. National kidney failure or transplant registries. Many centers have only paper records or incomplete local database. Underreporting to global observatory on donation and transplantation makes it difficult to plan and benchmark. This is the cultural barriers, beliefs and attitudes, awareness and education, and misconceptions and myths. Donor-related barriers, heavy reliance on living-related donors. Many potential donors are medically unsuitable, whether they have hypertension, obesity, or CKD, etc. Lack of long-term follow-up and protection for donors, fueling concerns about future kidney disease or financial hardship, and very limited paired exchange programs or other advanced living donor strategies like laparoscopic donor nephrectomy, for instance. So let's go to the emerging opportunities and strategies, policy, and let me just put the cable because it's warning me that it will die. Okay, the battery was about to die. I'm sorry. Policy and United Healthcare integration, including CKD, dialysis, transplantation, explicitly in national programs of the NCDs, the benefit packages of the United Healthcare and the insurance with protection against catastrophic health expenditure. Regional centers and twinning strengthens a network of regional transplant centers of excellence with twinning programs linking African centers to high volume units worldwide for training and membership. Deceased donor system development, establish and fund organ procurement organization, brain death legislation, ICU donor detection protocols, and transplant allocation policies. Data and registries, develop national kidney failure and transplant registries, financing and access to medicines, pooled procurement of quality assured generics like tacrolimus, MMF, etc., and long-term funding for immunosuppression and follow-up for the patient. Workforce development, regional training, fellowship in transplant nephrology, surgery, histocompatibility, pathology, and coordination, incentives to retain specialists and develop full multidisciplinary teams. Public and professional awareness, culturally sensitive campaigns with religious leaders, patient groups, and media to normalize donation and address myths. Of course, ISN support for Africa. There is Sister Renal Centers Program, Fellowship Training, ISN Transplantation Working Group activities, ISN Outreach Program, and ISN Advocacy. Sister Renal Centers, you have surgical nephrology training, capacity building, successful in multiple African countries. ISN Fellowship in Africa, training nephrologists and surgeons abroad, returning physician strengthens national programs. Besides, with the national fellowship programs like what we have with the AFRAN, they have a very good fellowship, transplantation fellowship program. We have also in Egypt another transplantation fellowship with the National Institute of Urology and Nephrology, and we already train many from our African brothers. And this is also, I think, in some other countries, it's a very good initiative. This is the ISN Transplantation Working Group, part of the webinars that we have done. In this webinar, we had also the IFKF as a joint session altogether. And of course, the ISN Global Kidney Health Atlas, which shows the Africa lowest in workflow, force funding and transplant access, critical data for advocacy and planning. strategic priorities, integration of the United Health Assurance, including transplant in national benefit packages and protect patients from catastrophic spending, workforce expansion by create transplant nephrology and surgery fellowships, coordinators, etc., and disease donation development, brain death laws, organ procurement organizations, ICU donor protection training, centers of excellence like in North Africa Hub, South Africa Hub, East Africa Emerging Hub as well, and registries, national end-stage renal disease registries, national transplant registries, and integration with ISN Atlas. The priorities, as you can see here, also for public awareness, engage religious leaders, media, and community education, and normalize organ donation, and ISN Africa roadmap, governance, workforce, funding, data, and public engagement. So to conclude, ladies and gentlemen, my dear colleagues, Africa has high need and strong potential. ISN AFRAN are committed to supporting expansion of safe, successful, and ethical transplantation in Africa. And I invite you all to visit Egypt and enjoy the Grand Egyptian Museum. And thank you all. Thank you.
Thank you so much, Prof. Mohammed Saleh ad-Din Zaki. I was there last week, and really, it's a great museum. Thank you so much for your outstanding presentation with an excellent overview of the actual situation of kidney transplantation in Africa, a critical situation, I can say, and of course, of the you speak about all the barriers of kidney transplantation and organ transplantation in general in our continent, and all the possibilities, all the field that we can work on to improve the situation. The second speaker is my dear friend, Professor Entisar Hadeya, one of the pillars of our AFRAN Transplantation Committee. Professor Hadeya is a nephrologist and lecturer researcher at the Faculty of Medicine and Pharmacy of Oujda at Morocco. She holds a PhD in social responsibility in health and a specialization in artificial intelligence and health care from Stanford University. Author of 60 Scopus and Dixit publications and several books and books chapters. She's actively involved in both the Moroccan Society of Nephrology, Dialysis and Transplantation and the AFRAN, of course. She also shares an association supporting kidney disease patients in the Oriental region of Morocco. She's also winner of several distinctions, including the Africanity Medal for her literary work 2023 and the Best Debate Prize at the World Congress of Nephrology 2025. She embodies a humanistic and inclusive vision of medicine, and she's very committed to help to improve the situation of kidney transplantation, organ transplantation in our continent. She's also not only a scientist, but also a literary figure, having published several novels that have earned her numerous literary awards across Morocco, but also multiple countries. So the floor is yours, Prof. Hadeya, to speak about the methodology of the elaboration of the AFRAN guidelines on how to create and to maintain kidney transplant programs in Africa.
Thank you very much, dear colleague and friend, Professor Munji, for this very kind and nice introduction. If you allow me to share my screen first and start my presentation. So here it is. Do you see the screen?
Yes.
Good. Okay. So good afternoon, everyone. It's a real great pleasure to be with you today for this AFRAN ISN joint webinar. I'm truly honored by sharing the floor with both distinguished speakers and moderators and to have this opportunity to present the methods behind the AFRAN guidelines on how to create and sustain kidney transplant programs in Africa. So these guidelines are the result of a collective AFRAN effort, bringing together experts from across the continent and supported, of course, by the AFRAN and specifically the AFRAN Transplantation Committee. And our objective was very clear since the beginning, is to move from challenges to actionable, realistic solutions that fit the African context. So in this talk, I will briefly walk you through how we structured the work, how we built consensus, and the methods framework we used to ensure that these guidelines are rigorous, practical, and applicable in diverse African settings. So let me start. Before starting designing our guidelines methods, it was important for us to recall the context. So because the reality of CKD in Africa shapes every strategy we design for transplantation. As Professor Salah said, we are facing a rapidly growing disease burden, a highly unequal impact, very limited access to transplantation, and of course, significant economic and regulatory challenges. As you can see, transplantation programs do exist in several countries, but their development is highly unequal. Some nations do have decades of experience and perform hundreds of transplants, while others have only recently started or have very limited activity or no activity at all. Funding models, donation models, and regulatory frameworks also do differ significantly, which creates wide variation in program capacity and sustainability across the continent. Besides, in many African countries, as Professor Salah said, the absence of robust registry data and the limited reporting from transplant programs make it really difficult to have a full picture of the actual activity. And this is exactly why input from African transplant workforce was essential in developing these guidelines, because global transplant guidelines do exist. They are valuable for sure, but their uptake across Africa has been fragmented because many countries do face structural, ethical, and resource mismatches that make direct application really difficult. And this is why an African-owned, context-specific, evidence-based framework is essential. Our goal was to bring all countries together, regardless of their starting point, and provide a coherent roadmap to support ethical, harmonized, and scalable transplant systems across the continent. So for the development of these guidelines, we first needed to clearly understand the real needs, the obstacles, and the regional variations across Africa. We therefore prioritized key themes such as eligibility, access, workup, and follow-up, and engaged in wide consultation with nephrologists and transplant stakeholders. And this process provided the foundational data through a survey that was conducted by our AFRAN Transplant Committee. So this survey was led by Dr. Malcolm Davis from our Transplant Committee. He included at the end 317 participants from 41 African countries, capturing the real-world experience and perceived barriers in kidney transplantation. Importantly, 28 countries reported having some level of access to transplantation, highlighting both the existing efforts and the significant regional disparities. So the main results of our survey show important variation in transplant regulation across African countries, with gaps at legislative, governmental, and institutional levels. They also highlight relatively strong activity in recipient and donor workup and follow-up, but persistent weaknesses during the peri-engraftment phase. Therefore, the main barriers revealed by our survey reflects real-world challenges reported by African nephrologists in their daily practice. These include the lack of trained professionals, limited access to immunological and histopathology tests, insufficient immunosuppressive drugs, weak policy and governmental support, and of course, the high cost of transplantation. So based on these results of the AFRAN survey, a dedicated guidelines subcommittee was formed within the AFRAN Transplantation Committee to start the development of context-adapted African guidelines. This is our AFRAN Transplant Committee under the leadership of Professor Mohammed Munji Basha. The guidelines subcommittee is coordinated by my colleague and friend, Dr. Wesley Tolkien. And I would like to take this opportunity to sincerely thank all our colleagues for their dedication and collective efforts within the Transplant Committee in general and the Guidelines Subcommittee in particular. So, as you see here, this is the first attempt of the guidelines, or how everything started. We initially proceeded with the development of the guidelines with a top-down approach. That means assigning topics and providing structured instructions but we quickly realized that engagement was uneven. In fact, we started by assigning topics to the transplant nephrologists and to groups within our committee. But as I said, the engagement was not really as expected. And this helped us understand an important lesson very early in the process. Effective collaboration requires ownership, clarity, and a simple, well-communicated plan. So to ensure a rigorous and structured methodology, we used the PICO framework: population, intervention, comparator, and outcome, to formulate clear, answerable clinical questions. And this allowed us to standardize our approach and align all guideline recommendations on well-defined clinical priorities relevant to the African transplant practice. So after our initial approach, what truly made the difference was opening the process to discussion and inviting volunteer experts within our committee to take ownership. By allowing self-selected leads for each topic, we strengthened engagement, accountability, and the overall quality of our guideline development. And building on the lessons learned from our initial approach, we adopted a modified Delphi consensus process. We developed an initial evidence-based framework, collected open feedback, works in subgroups, and refined the content through regular bi-weekly online meetings to ensure an inclusive and balanced consensus adapted to the African context. So as I said, to operationalize our modified Delphi process, we held structured online meetings. Here you see the dates of our meetings every 2 weeks. And during each session, the sections were presented, discussed, revised, and graded using the grade approach that I'm going to show in the next slide, allowing us to reach a shared and robust consensus across the different working groups. There are some photos of our meetings. And what about the grading system? Here's how we proceeded with it. We used the grade methodology to ensure transparency and consistency in our recommendations, integrating the quality of evidence, of existing evidence, of course, the balance between benefits and harms, patient values, and resource implications. And this process allowed us to formulate either strong or conditional recommendations and suggestions adapted to the realities of transplantation practice in Africa. And after defining how we applied the grade system, we then defined our grade adultment strategy. With adultment, I mean that we did not start our recommendation from scratch. We adapted also from the existing guidelines, we adapted them to our African context. We mostly worked on high quality guidelines such as KDIGO whenever possible, and adapted them to our context when needed, and then developed de novo recommendations where important gaps existed. And beyond the technical aspects, medical aspects, several sensitive and context-specific issues generated strong debates among the African experts within our committee, including eligibility criteria, donor prioritization, equity between public and private sectors, post-TB management, ethical questions, for example, around prisoner donation, for instance, and the urgent need for coordinated action at national, regional, and continental levels. And throughout this process, we faced concrete challenges, including the limited African evidence base, logistical constraints sometimes related to the time zones and connectivity during our meetings, and the constant need to balance scientific rigor with real-world feasibility. If we step back and reflect on the overall process, its main strengths were the strong sense of African ownership, the contextual adaptation of international standards, and the transparency of the methods. At the same time, we remain aware of our weaknesses, mainly related to limited local data and technical constraints. Overall, several elements clearly contributed to the success of this process. The choice of volunteer leads strengthened engagement and ownership. The fortnightly reviews helped maintain momentum. The Delphi method guaranteed inclusivity, while the grade system brought transparency and methodological rigor. Finally, the adultment approach allowed us to balance international standards with African realities and ensure true contextual adaptability. Besides, adultment strategy proved both flexible and efficient in our context. The shared understanding of African challenges created a common ground among experts, while the survey data helps us focus on real-life priorities. Ultimately, this work goes beyond academic guidance, as it also supports the development of coherent national and continental policies. And here's a summary of the whole process, the whole methodological pathway. We started with the PICO to properly frame the clinical questions, and we used the GRADE approach to assess and classify the quality of evidence. Through the adultment strategy, we tailored the recommendations to African realities. And finally, the Delphi process and the regular reviews ensured validation, consistency, and collective ownership of the final content. And you see here the table of our external international experts that have reviewed our final manuscripts, the final documents. You see they're from several regions of the world: Egypt, Tunisia, South Africa, Belgium, Nigeria, United Kingdom, United States, Morocco, and so on. At this stage, the process has reached its concrete outputs. The final draft is completed. The full editorial process has been finalized, and both internal and external experts' comments have been fully integrated. The document is now validated, and we are moving into the final phase, which is preparation for publication and wider dissemination. And this webinar is part of this process. So to conclude, these guidelines were designed to be both rigorous and realistic, grounded in our African realities and built with strong contextual ownership. We followed a structured process from PICO to GRADE and adultment, allowing both scientific rigor and adaptability. And importantly, this work is carried by the same team behind the Nouakchott Declaration, which represents a major landmark for advancing organ donation and transplantation in Africa. These guidelines are part of that same vision, strengthening policy frameworks, supporting implementation, and accelerating the development of kidney transplantation across the continent. Thank you.
Thank you so much, Professor Intisar Hadia. My congratulations really for this fantastic presentation, which brought us a comprehensive view of the AFRAN methodology guidelines on how to create and sustain kidney transplant programs in Africa. To continue, our final presentation will keep on this same topic, but now with an overview of the AFRAN guidelines. It's my pleasure to introduce Dr. Wesley Tulken. He's an associate professor and head of the nephrology at Dr. George Mukari Academic Hospital and Sefako Mangato Health Science University in South Africa. He is a clinician, a teacher, a researcher, currently completing his PhD at University of Pretoria, with his work spanning from chronic kidney disease, transplantation, genomics, and peritoneal dialysis. He has authored more than 20 peer-reviewed publications and plays an active role in advancing kidney care through the South African Nephrology Society and the African Association of Nephrology. Uh, the floor is yours. Thank you, Professor Tulken.
Thank you so much for the kind introduction. I really appreciate it. I'm just going to share my screen quickly. Can everybody see my screen?
Yes.
Okay, thank you. Thank you again for the kind introductions, and I'm honored to follow on after two such distinguished academics. I'm really grateful to being incorporated in this. So I'm going to be giving I'm going to try to give as much of a view as possible of the guideline document as it stands. It has been a mammoth undertaking for the last 18 or so months, where there have been 32 of us, and that represents I've been trying to work out how many years of experience. There are 32 nephrologists, each easily having over a decade worth of experience. So this is a Pan-African guideline that has been created by some dedicated clinicians, and I'm really honored to be part of this. And I hope I can do justice to the guidelines. I can only give you a taste. The guidelines are 90 pages long, and a lot of work has gone into it by some very, very dedicated people. So again, I take my hat off to the whole team and to Prof. Monji and Prof. Bomboye for their leadership and guidance, and the invaluable assistance from Prof. Intisar. I have no disclosures. And the overview is, I'm going to give you the structure of the guidelines, then the key legal and ethical instruments that we used. Then I'm going to talk a bit about the phased implementation model. And this is important because it has to be step by step. It can't just, transplantation is so complex, and the lead up to transplantation, so dialysis, crash landers, and pre-dialysis care, it is very complex, and it's not just one group of people, one person or small group of people. It is lots and lots and lots of people that need to come together. And the more you look at it, the more people, the bigger the team you need. And it is, you can't just do it suddenly. And that's one of the biggest hindrances, I think, is that a lot of the countries will have the infrastructure, but it's not integrated. And our guidelines are trying to address that, and the heterogeneity of the different levels within Africa, even in countries. I mean, in South Africa, there are huge disparities between the different provinces. So there's a lot of work that needs to be done, but it's not impossible, but it needs dedication. And then I'm going to talk about the strategic implication for African countries. Why do these guidelines matter? Chronic kidney disease it's one of the silent killers that affect all nations. But the problem with it is that it is so expensive. And And as was mentioned by our first speaker, the amount of catastrophic health expenditure that happens to patients who suddenly have this disease, they're feeling a little bit off, and then a week later they're in hospital in ICU getting dialyzed and feeling absolutely horrible, and their family financial safety is at risk. It is a horrible disease, very quiet, very silent, and we don't know the true extent in Africa. But we know it's rising fast, and we know that the traditional risk factors don't explain the disparities we see. And recently, there's been a few publications that have shown that by 2030, it's estimated more than 60% of dialysis patients worldwide are going to be in sub-Saharan Africa, or dialysis requiring patients, should I say. But only 1.5% of these patients currently have access to any dialysis. And on top of that, Africa contributes to less than 1% of the global kidney transplant. And this is mainly due to fragmented transplant access. And there's a need for more unified African governance. So what's already been covered, the survey results, the methods that we used for creating these guidelines, so the PICO, the grade, the development as well, and the Delphi process. And then the development process, which I highlighted a bit earlier. So there we go. So the current focus is going to be now on how the guidelines are structured. Then we're going to talk about a few of the key legal and ethical frameworks, and then the practical implementation. So the structure of the guidelines are, it's a 90-page document with 32 nephrology experts from 22 countries. And then it has been externally reviewed and validated. So a lot of work has gone into it. The first chapter gives us the context. Then chapter 1 gives us the context. Chapter 2 gives us the governance and ethics. Then we look at the human resources and infrastructure requirements needed for transplantation. Chapter 4 is quite important. It's the phased implementation that I was alluding to earlier. And again, that's very important. Then there is the clinical and technical standards, along with key performance indicators and things such like that are important for not only initiating but maintaining and growing. Because if you can't just go in and start something, then walk away. You have to start something, be dedicated to it, monitor it, nurture it, and let it grow. And that's what we are hoping to show with this with these guidelines. And then chapter 6 is future directions and holes in the literature that we've identified, and infrastructural problems that affect a lot of the African countries. So chapter 2, it is the ethical and legal framework. And what we did is we used a lot of international guidelines, such as the Declaration of Istanbul. There's the World Health Organization and the UN Charter on organ trafficking, and we looked at those and we identified we looked at it and saw how we could take what was there and put it into an African context. And we broke it down into deceased donor, living donor, and living related donor, and tried to integrate them into the various types of governance structures. Then we looked at the ethical and legal oversight committees and tried to give them mandates and composition and structure without being too prescriptive. You know, you have to walk a very tight line here to give decent advice and guidance without being too prescriptive. And it was difficult, but our colleagues are fantastic, and the amount of expertise there just on those Zoom calls was fantastic. So the structure of the guidelines, basically what we have is we have the chapter heading, then we have a description of what the chapter is. Then we go into the guidelines. And if you have a look here, so this is chapter 2.1, the National Frameworks for Governance, Financing and Coordination. So the idea is here is you have to have an overall governance and a framework to work within. Otherwise, you'll have people pulling in all different directions. Everybody's trying to do the right thing, but it becomes so cluttered. It's so difficult to monitor and keep track of things. So you need a national framework to work within. And this again is based on the World Health Organization guiding principles, the Declaration of Istanbul, and the UN Protocol to prevent organ trafficking. But basically, you need good, strong laws to help guide you do transplantation, because like organ trafficking is real. It has happened. It's happened in Africa. It's happened in other countries, and people will always try to do this because the fear of death with people with chronic kidney disease and dialysis is so high, and the drive for a transplantation and that drive for trying to get a better life is so strong that people will try and break and bend the rules. And a lot of the time, I don't think that people understand the gravity of the situation that they are putting the donors in who are illegally giving the kidney. But to come back, we have a statement. So here it says establish national kidney transplant legislation aligned with the World Health Organization, the Declaration of Istanbul, and the United Nations Protocol. We then have a grading, and here it's grade 1. So we recommend and it's grade A evidence. So it's very high level evidence. And then if you have a look here, each line is referenced. And what we have tried very hard to do is to at least put in one international and one African reference. Now, it hasn't been possible to do everyone like that, but that has been the aim. And to ensure that it is a Pan-African, African-centric guideline. So the international legal foundations that these are not the only ones that we used, but these were the ones that played the predominant role in the development of Chapter 2, was the World Health Organization, the guiding principles, the Declaration of Istanbul, and the UN organ trafficking protocol. These are all big documents. There's a lot that we needed to go through in each of them, but we've condensed it into a single chapter. But Chapter 2, if memory serves me correct, is probably one of the bigger chapters in the guidelines. Then we also used international transplant guidelines, and again, it's not just KDIGO and NICE, although we did use a lot of them. And it was fantastic, again, to see the working knowledge that the different people in the guideline committee had, and the opinions that they had. And there were so many nuances that, you know, if you read the KDIGO guidelines, you you think you understand them, but then being on these committees, you end up seeing so many other facets to the to these guidelines. So it was, again, it was fantastic. But this is what we used for our guidelines. And I want to highlight that we adapted it to Africa. We did not import things wholesale, but then again, we also didn't reinvent the wheel. We looked at the guidelines and we looked at the different documents, and we said, yes, that is very valid, or no, that is not valid in Africa. And then often there was some where there was a gray area or wiggle room. So there we kind of tweaked them and put them into the African context. And those were the ones that were the hardest to do. It's easy to accept what is pretty much obvious, and where there's a gaping hole, it's easy to fix that. But to tweak existing guidelines in how do I say it, to adapt something to the African context takes a lot, considering how variable the African continent is. And then we also had to contextualize it for the African law, African culture, and their different systems. And it wasn't easy, but it was very interesting to do. And again, it was a complex, time-intensive process that required strong leadership and dedication. And we did this for every 2 weeks for over 18 months. So basically, what we had to do in chapter 2 is we had to give a governance framework where we could advise on legislation, and we had to standardize we had to advise on legislation, we had to advise on ethical oversight and reporting, and advise on how national and regional transplant authorities and how to review. And we had to try and standardize consent, which is very difficult, even if you just take it in the different languages that are there. And also try and standardize organ allocation as well, which is quite difficult. So we also looked into living donation, and we had to highlight the need for voluntariness. We had to make sure that coercion safeguards are always there and present. And it's very difficult to do this because often you have to rely on colleagues to look for coercion. I mean, in your interaction with the patient, you will look for coercion, you'll ask the questions, but your time is limited. So you also send to social workers, or you send to the patients to psychologists. But now, how do you ask them to look for coercion, and how do you get them to report on that? So it's very difficult. And how do you actually lead this process? So it's definitely not perfect, and there will be no system anywhere in the world that is perfect to look for or detect coercion. But you do have to do a few checklists to make sure that you've done your due diligence. Financial neutrality, this is huge. Dialysis is very expensive, but and people will pay a lot of money to get a kidney, because the quality of life, often called dialysis life-saving torture. So people will pay a lot of money to get a kidney, but then that introduces so many it introduces various forms of coercion. So transplantation and donation should be financially neutral. So you shouldn't be paying the donor exorbitant amounts of money, but you also need to cover their travel costs, their costs due to lost wages, as was mentioned earlier. It's very complex and it is very nuanced, and you have to be very careful. And as I alluded to, psychosocial assessment is vital. Yeah. Deceased donation, we struggled. I didn't think that we would struggle a bit with the like legal definitions of death, but there was a fair amount of conversation on that. We had to get the a family approach method was finally accepted, and we also need in deceased donation laboratory readiness and turnaround times for the various tests that you need to do is absolutely vital. After brain death, you have a bit of wiggle room, but after circulatory death, it's it's very vital. An allocation, what came up directly and indirectly with this is the need not only for registries but for allocation systems that are fair and transparent, which is a huge thing. Chapter 3 was the basically how you develop your program and some operational guidelines. And again, there was an introduction here. And what we aimed to do is we aimed to show a core transplant team, so essential personnel that a country that is just starting out, what type of people will they need? What type of infrastructure will they need? What is the minimum investment that, from a government perspective, will they need to invest in, and what systems will they need to have? So that is the aim of this. And this is another way of looking at it. What is your minimum safe team? So you obviously need a core nephrologist, you need a transplant surgeon. And there was some debate as to, do you need a transplant surgeon? Do you need a vascular surgeon? Do you need a urologist? Do you need a mixture of all of them? And we had that discussion, and external reviewers also brought that up. And it was very interesting to see that, but maybe that's my maybe I've got blinkers on or something like that. I've been spoiled by having a transplant surgeon, a urologist, and a vascular surgeon at one transplant, at most of the transplants that I've done. So maybe that that shows my bias, I suppose. An anesthetist, I think, that's obvious. You can't have the surgeon doing the anesthetics or the nephrologist doing the anesthetics. A transplant coordinator is, in my opinion, absolutely vital. I know that we've graded it 2B, but you get much better outcomes if you have a transplant coordinator. Radiology and pathology and immunology support, you definitely need that. Radiology, without a doubt. Pathology, you don't need it on site, but you need easy access to it with a good turnaround time. And dialysis is vital in case you have a delayed graft function, or God forbid a acute rejection. You also have to have ICU availability. If everything goes according to plan, you can get away with a high care setting for a few days and then go to an isolated ward, but I wouldn't recommend that. I would recommend ICU. Then the next point is to have multidisciplinary expansion. So infectious diseases is very, very, very important, and especially ideally somebody who is trained on infectious diseases in the immunosuppressed host. Now, you would think that somebody who says an infectious diseases expert on immunosuppressed patients with HIV or autoimmune diseases would be able to do it in transplantation, but they've, at least with my experience with autoimmune HIV and transplant, vastly different presentations. Sometimes the same disease organisms, obviously like BK virus, that's not usually looked for in, say, HIV or autoimmune diseases, but each patient population has their own quirks, and you need somebody who knows how to deal with it. A transplant pharmacy is very, very, very useful. Dietitian is important, especially considering the major lifestyle changes and physiological changes that patients undergo with transplantation. Also, if they develop a NODAT, that a dietitian is useful. I cut off a social worker, but a psychologist or a social worker, and physiotherapy to start mobilizing the patient at appropriate time after the engraftment. Regional partnerships, I alluded to that a bit with the pathology people are saying you don't have to have pathology on site. It's helpful. The turnaround time is better. Having 24-hour access is also vital. Transplant patients are fickle. They change status very quickly. But having regional partnerships is a great way of starting a project. So regional shared surgical teams, HLA and pathology services, also donor-specific antibodies or panel-reactive antibodies, referral pathways for complex cases. Now, transplant patients become very complex, and you need a support system of people who are able to help you in these complex cases. It's invaluable. Telemedicine is something that I don't think we use nearly enough. I think we should be starting using telemedicine a lot more, especially in South Africa, where there's a lot of rural areas. I think telemedicine should be used much more often. And joint training and mentorship, you will go much faster, much further, and much quicker if you work together in a regional partnership. Infrastructure requirements also, so you have to have dialysis capacity, not just as a place to, I mean, if you look at the in South Africa, for example, in our public sector, we have a dialysis population of about 40 or 50 patients per million, where our transplant rate or prevalence is 6, I think it is, per million. So there's about a factor of 10 difference in that rate. So you have to have a dialysis capacity, and from there you will transplant the patients. But also, in case the transplant fails, so the patient can go back onto dialysis while you prepare them again for a second transplant. ICU access is vital, and not just any ICU. It has to be ICU trained in strict sterility and infectious disease prophylaxis protocols. And you need quick access, because these patients come in very quickly and they are horribly, horribly ill, and you can do a lot with them, but you have to have a team on standby that is fantastic. So you need to have that kind of access. Again, the lab and imaging readiness is vital, and drug availability. If you cannot do transplants, I mean, it'll be wonderful. You put the kidney in and the patient starts passing urine, and then you pat yourself on the back. But 2 months down the line, the patient comes in or end-stage renal disease again, and you find out, oh no, they kept on missing a medication, or it was late or something like that, and they ended up having a rejection episode. Chapter 4 is is quite an important chapter. This is the systematic phased-in approach. And you'll notice there that we haven't just said systematic phased-in approach. We've said systematic phased-in approach with monitoring and evaluation. And this is incredibly vital. If you don't monitor what you're doing and looking for errors or mistakes in such a complex system, your risk of failure is going to become high. So if you don't have good reporting, good monitoring, and good two-way communication between the different parts of this complex system, things are not going to work. There are, and people are going to pull in different directions, so it's not going to work very well. So basically, what the phasing, the different phases are, is you need to get right your legal framework, and you need to get your financing. As was mentioned by our first speaker, a lot of the patients are financing out of pocket. Now, dialysis itself is expensive, but the initial transplantation is immensely expensive. The economic savings in a kidney transplant are only really realized probably at the end of the first year, or probably more in the second year. It depends on the country. Each country has a different cost. So, I can't tell you when the financial neutrality comes in, but you need to make sure that there is a proper funding model that takes into account the cost of dialysis, cost of transplantation, the cost of the workup, cost of monitoring, and puts that into some functioning model that is right for the country and right for the patient, the doctors and nursing staff, and the whole team, which is important. Phase 2 is now you have your legal and financing set up. How are you going to monitor it? How are you going to make sure that the wheels don't fall off and stuff like that? Then phase 3 is how you select your patients, how you work them up, what you need to work them up, I mean, something simple like how often should you do a HIV test? How often should you do a hepatitis B or C? I mean, that type of thing, you need to know prevalence of the diseases in your country and the likelihood of the patient contracting it. Put that into a patient who presumably is having hemodialysis. What is the risk of them having blood exposure accident and so on? Then phase 4 is going to be the early operations, where you are getting your hands dirty and your team is going in. There's some monitoring from some regional partners who've had experience, and they watch and they see how things are going, and they step in when there's a problem. They step out and let the early operations go in. You have your teething problems, and then you go into stage 5, or phase 5, which is the self-reliance. So that's when your regional partners step back and they say, okay, you guys are doing well. You've had this problem, that problem, but A, you can do it, and B, you know how to monitor yourself to see where there are problems so that you can keep on going forward. And then phase 6 is where becomes sustainable. People start seeing that that this system is really working. The trust starts growing, and and you get more and more public buy-in. And it is very, very, very difficult to get there because there are so many different obstacles that you need to go through. So this is the chapter 4, the phase 1. The legal, ethical, and funding frameworks. Again, you see the UN Charter coming in here, the World Health Organization, and the Declaration of Istanbul coming through here. But the ethical framework as well is you need national and local transplant ethics. Sorry, you can't see my pointer. So you need national and local transplant ethics committees. and the local committees need to review probably on a monthly basis the selection committee, and then report to a national, so you have oversight. And then there needs to be a two-way communication between the two there. So now the examples of how this has to be applied and how it has to be how to, the variation that has to be applied to an African context. I mean, there are some countries with no program whatsoever. And then there's countries with only living donors, and then there's countries with established programs. And this is a horrible simplification. And you know, like if you look at South Africa, where it's got established deceased donor, established living donor, that's not to say that there are not ongoing problems. It's because it's a complex system, and you need this continuous evaluating and monitoring to make sure that your system doesn't crumble. Sorry, I'm battling with this Zoom bar. Okay. So chapter 5 is the medical and technical preparation, but what this starts leading to is actual, how are we going to start doing this? So you've got your phased in approach, and now what tools do you need to start doing the transplants? How are you going to actually do these things? How are you going to monitor it and stuff like that? So what we have done is we've got an Africa-specific preparation and follow-up for kidney or donor recipients, and the aim here is going to be ideally is preemptive, to avoid dialysis at all if you can, because of the mortality benefits of transplants, the financial benefits to both society and to the patient. And we also touch on a bit of dialysis access preparation as well. Something that we had to talk a bit about was the immunological and genetic risk management. So obviously, as a standard across the world, you want to minimize blood transfusions to minimize HLA sensitizations. But now the APOL1 risk variance, so we've given it a 2C, but it's still an evolving area there. And we said to screen donors, obviously not because not recipients, because that's where the risk comes in. But you know, with things like inaxaplin for APOL1, it's so difficult to give good quality data advice here, because there's not that many studies on APOL1. There's been a couple in Nigeria and Western Africa where APOL1 is has been reasonably well studied, but to actually find prospective studies on APOL1 and stuff like that is actually very difficult. So to give good advice on APOL1 is going to be difficult. And you know, we've said screen donors for APOL1 in high prevalence areas, but we haven't talked about the protective variants. We just looked at the risk variants, so it's complex. And then something I also wanted to show that I actually didn't mention in the beginning is at the end of each sub chapter we've got key takeaways, and so we can use that in the how can I say this? it's like a snapshot of each subchapter, so that can be quite useful as well. But here, I mean, we try to promote in 5.1, we say promote and counsel stage 5 patients, promote early referral, tailor genetic and infectious screenings to your local your local patterns, ensure vaccination, and use telemedicine and structured follow-up. And I think structured follow-up is very, very important here, not only for the recipient, but for the donors as well. We've also touched on cultural and legal issues that are Africa specific. And again, I need to highlight how difficult it is to give guidance on something that varies so much. But things that we need to be very careful on is to define your death using locally validated scientific methods, but also make sure that it is done in, it takes into account local religious practices and cultural beliefs. You need to make sure that the patient is brain dead with at least 2 experienced and independent physicians. And we deliberated a lot on what is experienced. It's very difficult. Is it just someone who's been practicing for 5 years? That's the general rule in South Africa here, but is that enough? I mean, we weren't certain, but it was a lot of discussion on that. You also have to have living donor safeguards and consent, and this ties into the legislation part in the beginning, where you have to develop country-specific laws defining your eligibility for living and related and unrelated donors. Another very important part here is subchapter 5.3 is key performance indicators, and this was you'll see that we battled with the level of recommendations. It needs to be there. It has to be there. The key performance indicators have to be there and have to be monitored. But to find good evidence for that was quite difficult. But we have a list of key performance indicators that are very core to being able to monitor and ensure a good transplant system. And key performance indicators are part and parcel of the continuous quality improvement process. And here we found stronger evidence for it, but we have a few quite a few continuous quality improvement process points that are in the guideline. And then our future directions is we need to start developing policy and aligning it with what the population needs are. We need to build capacity and avoid the brain drain that we see, because Africa is a fantastic place. I don't know, I mean, everybody on here undoubtedly knows that Africa is a fantastic place, and we can do so much here. There's so much that we can do. It is fantastic, but we just need to work together. And that leads to my last point here on regional collaboration is vital. And that's exactly what AFRAN is doing with this and what ISN is doing. So it's fantastic. Chapter 6, our future directions. And basically this talks to where our weaknesses are, but where we need more research. And what we need is data infrastructure. That is absolutely clear. But Africa-focused research, prospective studies. It doesn't matter what type of study you can think of. Almost certainly there are very few prospective studies that are African-centric, and we need to change this, and quickly. In closing, these guidelines are African-led, evidence-based guidelines that we have developed using the literature that is out there, that is high quality. It has been led by people with decades and decades and decades of experience, who are very dedicated and are only interested in improving transplant outcomes in Africa. Now, this is the first step in turning principles into practice, and how we can improve the general population of your country and of Africa as a whole. And these guidelines are being developed as a shared tool for everybody to use, and to improve healthcare, improve transplantation, and improve patient outcomes. So in closing, I'd like to say thank you to the African Transplant Committee team. It has been an absolute honor to work with you. It has been fantastic listening to the different points of view, to how you can, like, the facets of information in just one sentence, and how many different facets of interpretation you can have there. And I have grown, and I'm immensely grateful to all of my colleagues, and our chairs, Prof. Bach and Prof. Bomboye, and to the rest of the team. Thank you so much. And I can't wait to share the full guidelines with everybody. And I really hope that they help you. Thank you.
Thank you so much, Professor Wesley Tulken, for walking us through the AFRAN guidelines. Actually, I'd like to thank all the speakers for their excellent presentations and insights. And of course, my co-moderator, Professor Mohammed Basha, for the exceptional moderating and planning of this session. We will now move to our open discussion. I hope we still have some time for some few short questions. So I invite all the panelists to join us. I invite our colleagues in the audience to share their questions and comments on the Q&A box. And maybe I could start with a very short, brief question. So we have the World Kidney Day now focusing on environmental sustainability. And we all know that kidney transplantation is one of the most important and greener solutions that we have for chronic kidney disease. Do you think this can be an additional factor in bringing and speeding change in the African continent and globally towards what we have debated today?
Well,
So,
yeah, please go.
sorry, Prof. Zaki, please go ahead. Yeah.
Please, no, go ahead. Please, Professor Wesley, go ahead.
Yeah. So I think it's something that we can't ignore. If you take water availability in Africa, I mean, South Africa itself is, we don't have that much water. Obviously, there are some countries with far less water than us, but dialysis uses a large amount of water, and we can improve on it. We tend to focus on getting the service out there, and we don't look at efficiency right away. But yes, we will have to make it more sustainable. It will be needed to be in there. But at the moment, we're trying to get the guidelines out there and functioning. But it's definitely something that we need to get going. It needs to be in the guidelines, and it needs to be hopefully it will come in the governance and oversight part.
Many of our speakers of our participants ask if the guidelines are published. Not yet, in progress. So I hope very soon you will be you can have the final version of this guidelines published in I hope in a big journal.
I see a nice question here in the Q&A box about, do you see it, the first question?
Yes, it's about what is the critical success factors to establish deceased organ donation program in a country that has all related laws, but inactive deceased organs donation program or very low numbers of deceased donors.
This is a very
Yes,
nice question. Could I answer? Do you allow
yes,
me?
of course.
Yeah, as I said, it's a very nice question because the core answer, I would say, is education. Therapeutic education for the patients when they reach advanced stages of kidney disease, and the continuous raising awareness, not only in campaigns, but continuously. And we said that in the guidelines. There is a part dedicated to that in the AFRAN guidelines. And of course, this raising awareness in order to correct the misconceptions and the misknowledge related to brain death. And of course, in these awareness campaigns, we should try to get supported by religious figures, law experts, sociologists, in order to do that, and highly respected celebrities, the media also. This is very, very important, and it's one of the main ways to overcome this issue.
Just to add, Prof. Hedea, about the situation in Africa, only three countries have a deceased donor kidney transplantation programs. It's South Africa, Tunisia, and Morocco. And it's really very, very, it's not enough, of course, to our continent. And I would like to add also that awareness campaigns should be for the public, but also for the health care providers and also for the patients, because we see in many publications that patients also refuse to be transplanted from deceased donors because of some and many religious concerns.
I want to add something for what Augusto said, the question for Augusto, and what Wesley said about the green nephrology and water shortage, is that there are some tools, even in the practice, not necessarily to have a green facility from the beginning. Actually, this is something most of the new facilities should focus on, but on the existing ones, now there are some tools in dialysis machines, like what they call the autoflow and other things that reduce the water consumption by almost 20%, 24% of the water consumption during session, which is a huge amount. So this is an important thing to be kept in mind. For the question of the how to establish the deceased organ, I do agree with Professor Hadea and Professor Mungi, and I want to focus that the main barrier, in my opinion, in Africa is the traditional, not even the religious, traditional barriers are immense. And the most important thing, in my humble opinion, is the lack of trust in the system. Many of the individuals have this lack of trust. They think that there is inequitable access to organs, And if this program was implemented, the benefits will be mainly to those who are rich or powerful or whatever. So we need to build this trust with the public, and to assure them that it's a very blind operation. There is no bias in this organ allocation. If this happened, then we would be able to have this program faster. Last thing, I can see that my dear friend Khadija Habshi, Professor Khadija, who I want to congratulate her for being elected as the Secretary General of the MISOT, the Middle East Society of Organ Transplantation. And she's asking about the need for balancing between rigor and feasibility. It's a big challenge, as she said. And I think the point of creating our own guidelines in Africa, the local guidelines, because you can someone can say that guidelines are everywhere. Why do we need to establish a new guidelines or African guidelines? This is exactly why we we need this, because we have to tailor the guidelines, we have to customize the guidelines to the resources, to the available resources in our country, in our continent, sorry, to the beliefs, norms, whatever, ethical, geographic, everything differs from one part of the world to another part, to the financial burden that our countries can face if we implemented the guidelines as such, from which has mostly been done by well-developed countries, high-income countries. For instance, if you have to say that all patient recipients should receive induction by thymoglobin or antithymocyte globulins, this will put more burden on our system. But if you choose the high risk and define high risk from low risk, and this is an example, I'm giving just an example, that would reduce the cost and will make governments able to cover more and more. So it is important, of course, not to go beyond or below the acceptable levels of safety and good practice, but we can tailor our guidelines according to our needs and our resources.
Yes.
I also just want to make a mention on the deceased donor issue. I think transparency is absolutely vital. The other thing that works really well is having a transplant coordinator come and do the counseling of the family, not the nephrologist or the transplant surgeon or the treating doctor of the patient who is now deceased, but getting somebody who's out of the system, who's very well trained in grief counseling, and who is very sensitive to cultural and religious norms, who comes in and speaks to the family of the recently deceased. That, I think, is absolutely vital. If you don't do that, you're gonna battle. And transplant coordinators are fantastic in that, and they're usually ICU trained nurses, so they are busy looking after the deceased person. The deceased person is usually very difficult to maintain. I don't know another word for saying that. So invest in the transplant coordinators and the people involved in the transplantation, and the care of the so the people involved in the transplantation must steer clear, and the people who are involved in the care of the immediate care of the deceased must steer clear of talking to the family. Otherwise, that's it's too much of an emotional burden, and it's not fair on the family of the deceased.
Another point on which we focuses and we insist during the elaboration of these guidelines is the importance of the collaboration. The collaboration, the regional collaboration and collaboration between African countries, because it's very difficult to have all the facilities in the same country with low and middle income with the immunological laboratory, the pathology laboratory, the pharmacology laboratory, and so on, so that for some facilities we can collaborate together to to transfer, for example, samples for the workup, for the preparation of donor and recipients, and then for the diagnosis of some complications. So I think that with our other projects, the Directory of Organ Donation and Transplantation, that we are in progress, our committee work on this big project also. I think that we will allow all the colleagues, the African colleagues, to have contact to start their program and to maintain their kidney transplant programs with the help of other countries and other colleagues. Yes, Dr. Saleh or Dr. Hadiya, please.
Well, I think we're now in the closing remarks. It was a great pleasure and immense honor for me to express how proud I am to participate in the launch of the very first kidney transplantation guidelines in Africa. Actually, this is a milestone. It's just not only a scientific publication, but it represents a real turning point in the trajectory of kidney transplantation across the African continent. One that will undoubtedly have a profound and lasting impact on the future of transplantation in Africa. Of course, developing guidelines that reflect the African reality, respects the available resources, as we mentioned, at the same time, harmonize with global standards is exactly the kind of foundational step we need to extend the umbrella of kidney transplantation across Africa. But of course, keeping in mind that this will be done in a correct, safe, effective, scientific, and ethical manner. I really salute everyone who contributed to this pioneering work, and I'm proud to have served as one of its reviewers. I also reaffirm my commitment to continued collaboration between the International Society of Nephrology, represented by the ISN Transplantation Working Group, that I have the honor to chair this group right now, and of course with the AFRAN Transplantation Committee. Together, we look forward to further strengthening our joint efforts to achieve our ultimate goal, which is delivering the highest quality of care to our patients across Africa. I thank you all for your kind attention. Thank all the distinguished professors, Professor Mungi, Professor Hadiya, Professor Augusto, and Professor Weasley for their very eminent and inspiring presentations and for their tremendous efforts. And I thank all the participants in this webinar. And God willing, we will meet again soon in future webinars. And I am looking forward to seeing you all at the World Congress of Nephrology in Yokohama in Japan, March 2026. Thank you, and God bless you all.
Thank you very much, Professor Zeki, for your insightful closing words. I would like also to extend my warmest thanks to our three distinguished speakers, Professor Mohammed Saleh Din Zaki, of course, from Egypt, Professor Intisar Hadeya from Morocco, and Professor Wesley Tulken from South Africa for the clarity, relevance, and impact of their presentations. A warm thank also to my co-moderators, Professor Augusto Cesar Suarez dos Santos Jr., and to all of you who joined us today from across Africa and beyond. This AFRAN ISN joint webinar has allowed us not only to review the current landscape of kidney transplantation in Africa, but also to highlight concrete pathways for progress, especially through the upcoming AFRAN guidelines on how to create and maintain kidney transplantation programs in Africa. So thank you very much. The AFRAN Transplant Committee has many surprises, and I hope soon we'll present you during congresses and during webinars our surprises, our work, the work of a big team that I thank very much in this occasion. Thank you very much, and see you soon.
Thank you.
Bye.
Thank
Bye-bye.
you, everyone. Have a
Thank you. Bye-bye.
great evening or day.
Bye-bye.
Yes.
Bye-bye.
Bye.